Hello, my name is Chaplain Heather Baggett, and I will be your instructor today as we learn about spiritual and emotional care during perinatal loss or infant death. Our 4 course objectives for today's session are: 1. Recognize common emotional responses patients and families have to perinatal loss or infant death. 2. Identify what resources CHI St. Alexius Health has on hand for patients and families dealing with perinatal loss or infant death, and answer some frequently asked questions. 3. Demonstrate scripting to help care providers talk to their perinatal loss or infant death patients and families about their spiritual and/or emotional distress. And 4. To discuss the emotional responses of care providers who work with patients and families dealing with perinatal loss or infant death, and identify some healthy methods of coping and self-care. As I present the following common responses, it is important to remember that while guidelines are useful, they are not universal. Everyone deals with loss differently. A person may stay in one emotional response through their entire stay at the hospital, or they may move back and forth between multiple responses. Especially in those first minutes and hours, there is no wrong way to respond. You may not be able to fathom why a person is responding the way they are, but keep in mind, they are possibly experiencing the worst day of their life. If in doubt about how to respond, it is hard to go wrong with remaining calm and doing your best to be empathetic and compassionate. Shock is one common emotional response to trauma of any kind, but perinatal loss or infant death in particular. Shock occurs when someone's emotional and spiritual equilibrium has been so fundamentally rocked that they are unable to respond to anything. It is almost like their system is overwhelmed and everything else becomes white noise. Some common signs of emotional shock are flat affect, staring off into space, a refusal to respond verbally, and pretending to be asleep. Several helpful ways for you to respond to emotional shock in your patient or their family are to speak calmly, make as few demands as possible, continue to explain what is going on and what to expect, even if you get no response. Give the patient and their family time alone to process if possible, and use a family member that is not exhibiting shock as your primary contact. Grief is probably the most commonly expected response to a perinatal loss or infant death. Grief can be difficult to define because it has so many manifestations. However, Merriam-Webster defines it as a deep and poignant distress caused by bereavement. Some common signs of grief are tears, shaking, loud crying or yelling, silence, the need for physical contact such as hand-holding or hugs, fatigue, and detachment. Several helpful ways for you to respond to a patient or family member exhibiting grief are to provide tissues and water as needed. Listen if the patient or family wants to talk. If both you and the patient or family is comfortable, you can offer a hand to hold or a hug. Turn the lights down. Keep other staff, patients, and family members calm if the grieving family is loud. And finally, and this is often the most difficult thing to do, you can sit in silence with them. Anger is a strong feeling of being upset or annoyed because of something wrong or bad. I cannot imagine something more wrong or bad than losing a child. It is often easier to feel anger than grief because its focus is usually something outside of yourself. Instead of feeling the pain of a loss, a person expresses anger at the care team, anger at their family, anger at God, anger at themselves, or sometimes just anger in general. Several common signs of anger are raised voices or yelling, tears, constant questioning, blaming, passive aggressiveness, headache, fatigue, or increased blood pressure and heart rate. When dealing with someone responding to loss with anger, keep in mind that if they are expressing their anger at you, it is usually not really you that is to blame. Their anger is not personal. It is born of extreme distress and the need to find someone at fault for something that is usually no one's fault at all. Remembering this can help you to respond helpfully instead of with your own anger. Some good ways to respond to a patient or family member exhibiting anger are to stay calm, listen respectfully, respond honestly, even if that means saying "I don't know," resist getting defensive and responding with your own anger, and take a break from that family if you need to. Efficiency is the ability to do something or produce something without wasting materials, time, or energy. It might seem odd to include this in a list of emotional responses to perinatal loss or infant death. However, much like someone responding with shock, someone responding with efficiency is overwhelmed. They are using so much energy trying to hold the reality of their loss at bay that the only way they can function is to be as efficient as possible. It is not a lack of feeling. Rather, it is an excess of feeling that they do not feel prepared for or know how to deal with. Alternatively, some people are extremely private in their emotion and may simply be waiting until they get home to express themselves. They know their loss is so great that they won't be able to hold it at bay for long, so their only choice is to do everything in their power to get home as quickly as possible. Several common signs of efficiency are a seeming lack of emotion, a desire to know exactly what they need to do and how long it will take, repetitive questions, a focus on the details, and a desire to leave the hospital as quickly as possible. Several helpful ways to respond to someone expressing themselves through efficiency are to be as quick and prompt as possible. Answer any questions in reasonable detail, even if you have already answered them. Provide frequent status updates about paperwork, tests, lab work, orders, etc. that the patient may be waiting for, and do not judge them for their seeming lack of emotion. Finally, sometimes family members who are responding in a different way become confused or hurt at the patient's seeming lack of emotion, wondering if the patient is even feeling the loss at all. If this is expressed to you, you can explain the efficiency response to the patient's family members. Sometimes it is helpful to understand how men might respond differently during perinatal loss or infant death. While male grief and female grief are not inherently different, often men have more pressure from society to respond in a particular way or to not respond emotionally at all. Therefore, men often don't feel as comfortable expressing their feelings. They are pressured to not cry and to remain strong for the rest of their family. For this reason, you may find men responding with anger and deficiency more often than not, because those are societally acceptable ways for men to express themselves. Another reason men might respond differently is that mom's experience and dad's experience of a pregnancy can be very different. Mom has had time to bond with the child that is growing inside of her, while dad has not had that same opportunity. Therefore, if a miscarriage or fetal demise occurs, mom is often mourning the reality of her child, while dad is mourning the idea of a child in the future. This can be a particularly difficult disconnect for parents to deal with. Mom can be hurt that dad is not grieving at the same level that she is, and dad can be frustrated and guilty that he is not able to give mom what she needs. Some good ways to address both male and female emotional distress are to be sure to speak to both mom and dad or any other family members equally about spiritual and emotional issue. Give dad or other male family members permission to grieve if they need it, and give the family privacy. While it can be very difficult to provide care to patients and families experiencing perinatal loss or infant death, CHI St. Alexius Health does have a variety of resources available to you. In this section, I will be identifying what those resources are and answering some frequently asked questions. Your first and most valuable resource is your colleagues. At CHI St. Alexius Health, we value the concept of treating the whole person. While you are trained or certified to meet the patient's physical needs, there are members of our staff who are trained or certified to meet the needs of their minds and spirits. The way to provide the best care possible to a patient is to utilize the entire interdisciplinary care team, including your chaplains and social workers. Spiritual Services is available in hospital for immediate response Monday through Friday from 0600 to 1800. During this time, it is possible to ask specifically for the Women's and Children's Chaplain. If she is in hospital, she will respond as quickly as possible. You can reach the on-call chaplain by paging 0713 24/7. If it is the evening or the weekend, we will be coming from home. This means up to a 40-minute response time, especially in the winter. We will often ask if the patient or family has requested to see a chaplain, and if they are willing to wait that 40 minutes before we arrive. This is so that the family is aware of the timeline and does not become frustrated, and also so that we do not come in only to find that the patient or family isn't ready to talk to a chaplain, doesn't want to talk to a chaplain, or has already gone home. We will also usually ask what religion the patient or family is. This helps us to coordinate the appropriate care as quickly as possible. For example, if the patient is Catholic and wants a priest to anoint their child, the on-call chaplain can call the priest immediately from home. This will cut down the patient's wait time because the priest will be able to leave right away instead of waiting on the on-call chaplain to get to the hospital, talk to the patient, and then call the priest from there. Spiritual Services can provide spiritual or emotional support, prayers, a baby blessing or anointing, naming ceremony, or baptism if the baby is born alive but will soon die. We can also help contact a faith community leader from the patient or family's faith community at the request of the patient or family. Social Services is also an integral part of the interdisciplinary care team. Social workers are available in hospital Monday through Saturday from 0830 to 1630 and Sunday from 10 to 12. You can ask specifically for the Women's and Children's social worker Monday through Friday, and if she is in hospital, she will respond as quickly as possible. You can reach a social worker by paging 0696. A social worker can provide emotional counseling to the patient and family. They can also help provide the patient and family information about funeral requirements and help them find a funeral home. Additionally, they can provide and discuss written resources for emotional support or education. Another resource we have for our families experiencing perinatal loss or infant death is our memory boxes. The Toll Friends Memory Box program donates boxes free of charge to the hospital to be given to families mourning the loss of a child before birth or in the first few months of his or her life. Their stated reason for limiting the boxes in this way is that a family losing an older child or family member already has photos, memories, and memorabilia from that person's life. When a mother goes into the hospital to have a child and loses the newborn, they do not have the benefit of the photos, memories, etc. The box is a way to give the family something to hold on to and to affirm the life of the child, no matter how brief. Boxes are hand-painted by volunteer artists and usually include designs geared toward either boys or girls, as well as some designs that are gender neutral. Because these boxes are painted to order, sometimes it can take up to 6 weeks to get new boxes in. If you are running low, let Spiritual Services know before you run out so that we can order more boxes for you. You can also put a commemorative birth certificate, certificate of blessing, grief materials, or any small memorial items in the box at the patient or family's discretion. The box will also sometimes include a poem, quote, or note placed there by the artist. Furthermore, if the patient or family wishes it, we have a dedicated camera that is stored in labor and delivery that can be used to take pictures of any dead or dying baby. These photos can then be saved to a CD and placed in the memory box, or given directly to the patient. CHI St. Alexius also has many written resources that can be helpful to patients and families suffering the loss of a child. The primary resource we use is a short book called Empty Arms. The author shares her experiences with miscarriage, stillbirth, and an ectopic pregnancy, and gives guidance and encouragement to others who are going through a similar experience. We also have 2 pamphlets that let patients and families know what kind of support they can find once they leave the hospital. The first is the Angel Babies pamphlet. This gives the patient and family information about a local support group for people who have lost their children to miscarriage, fetal demise, or infant death. The second is a card giving them information about CHI St. Alexius Health's annual service of remembrance. Next, there is a booklet that was produced by our hospital that answers questions about the physical, emotional, social, and spiritual symptoms of miscarriage. Finally, there is a memorial book which allows parents to write out memories of the pregnancy and keep a record of the love they have for their child. We also have several additional resources that are available if you think they would be helpful to a particular patient or family. The first is a care note called Mourning a Miscarriage. This booklet focuses on 4 aspects of forgiveness that can help the mourning process: forgiving yourself, forgiving how you are feeling right now, forgiving others, and forgiving God. You can get this booklet from the Spiritual Services Department. The second is a pamphlet for family and friends on how they can be supportive to a loved one who is experiencing perinatal loss or infant death. The third is a pamphlet focused primarily on how fathers experience grief. The fourth is a guide from the North Dakota Department of Health on how to plan a funeral for your child if you so choose. Finally, there is a storybook meant for young siblings. All these can be very valuable in particular situations, but may not be appropriate for every perinatal loss patient you have. These are some of the practical questions I hear most often from patients and families experiencing perinatal loss. The first is, do I need to have a funeral for my baby? The answer is that if their baby was born at a greater than 20 weeks gestational age, then they must have a funeral for their baby. The second question is, how do I find a funeral home? The answer is that the social worker can go over that with them. If it is after hours and a social worker is not available, you can assist the patient with using the internet to find a funeral home. The third question is, even though my baby is less than 20 weeks gestational age, can I still bury her or him? The answer is yes, of course. The last question is, what happens to my baby of less than 20 weeks gestational age if I choose not to bury her or him? The answer to that question is that the hospital will keep her or him stored respectfully in pathology. Once a year, all the babies that were not buried are put into a coffin that is handmade by our carpentry department. That coffin is then buried in St. Mary's Cemetery during our annual service of remembrance. If you want a particular item, such as a piece of clothing or a rosary buried with your baby, we can facilitate that as well. If a patient or family member asks a question that you are unsure of the answer to, feel free to call Spiritual Services, Social Services, or your manager for help getting your family the correct information or assistance. The last thing to discuss in the resources section is a list of common pitfalls. The first common pitfall I'm going to address is being overly clinical in your language. You have been trained, many times for years, to learn the proper clinical terminology and how to utilize it to let your colleagues know best how to care for a patient. That is a very valuable skill. However, when speaking to a patient or family member experiencing a significant loss, it can be important to set some of that clinical language aside. They are often overwhelmed by what they are experiencing and may not have the presence of mind to parse what you are saying. For example, instead of referring to what the patient gave birth to as products of conception, ask them if they have chosen a name for their child. If they have not named their child, you can still refer to him or her as their child or their baby. This shows the parents that you care about them and helps them connect to their child, which can help them in their grieving process. The second pitfall I am going to address is making assumptions and not asking questions. Most everyone has experienced loss at some point in their life. This can give you some valuable insight into what patients might be thinking or feeling. However, it is important to recognize the might in that statement. Do not assume that they will want or need the same things that you wanted or needed during your loss. If there is something you think might be helpful or useful, ask the patient or their family before assuming. They will appreciate your genuine concern, even if what you are offering is not something that they needed. The third pitfall I am going to address is not understanding or internally judging seemingly inappropriate responses. For example, a young woman whose husband is deployed abroad experiences a miscarriage. In addition to grieving the loss of her child, she feels relieved. She was scared of raising her child without her husband to help. She may feel guilty or like she is a horrible person for feeling relieved that something she was scared of is not going to happen. It is possible for grief, relief, and guilt to be felt at the same time by the same person. And this does not make her a bad person. It just makes her human. Every seemingly inappropriate response has a reason, even if someone is not able to adequately express it during the initial hours after experiencing a loss. The fourth pitfall I am going to address is offering platitudes. When we are uncomfortable and unsure what to say, platitudes are often the first thing we go to in order to respond. Platitudes are things like, well, at least he's in a better place now, or I guess God just needed another angel tonight. Instead, if you feel like you have to say something, but don't know what, you can respond with, I really don't know what to say right now, but I'm here with you. Or, I can't imagine what you're going through right now. Platitudes are often an effort to make it better, but someone who has just experienced a loss isn't ready to make it better yet. The last pitfall I am going to address connects to the previous one, trying to skip straight through grief to hope or acceptance. In other words, trying to make it better. As healthcare professionals, our job most often consists of trying to make it better. Medical science is founded on this principle. However, sometimes things need to heal, and skipping straight to better actually makes it worse. A truly empathetic response will require you to sit with your patient in their grief, rather than trying to pull them out of their grief. Sometimes it can be difficult to know what to say or how to say it when speaking to patients or family members dealing with spiritual or emotional distress. Spiritual distress is a disturbance in a person's belief system. As an approved nursing diagnosis, spiritual distress is defined as a disruption in the life principle that pervades a person's entire being and that integrates and transcends one's biological and psychological nature. Emotional distress is defined as mental distress, mental suffering, or mental anguish. In this section, we will go over some scripting suggestions on how to talk with patients exhibiting various emotional responses to spiritual or emotional distress. First, there is a short video narrated by Dr. Brené Brown on the difference between empathy and sympathy. Second, there is a video with some suggestions on how to introduce spiritual services and social services as part of the interdisciplinary care team. Finally, there will be a set of 4 vignettes based on the 4 common emotional responses discussed earlier in the presentation.
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied professions, very diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here, and you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with at least. Yeah. And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
If either of these get too bad, let me know. Also, I just want you to know, whenever something traumatic like this happens to your body, all of you is affected. I, as a nurse, am here to take care of your physical needs, but we also have people who are trained to deal with your emotional or spiritual needs as well. And at some point today, the social worker and the chaplain will stop by to visit with you.
I'm not really sure what they can do for me.
Well, when they stop by, they can let you know what they can do for you, and then you can decide together if there's anything they can help you with.
Okay, thank you.
You're welcome.
I don't really want to talk to anybody else right now.
Well, when I page the chaplain and the social worker, I will let them know that at this time you're not ready to visit with them, but just know that they will stop in later on today at some point to see if there's anything that you need.
Okay, thank you. I really don't know how I feel right now. I'm just so lost. Do you think the chaplain could come right now?
Sure, let me step out and page them, and if it's going to be more than a few minutes, I'll step back in and let you know.
Thank you so much.
Hi, Mrs. Jones. My name's Amy. I'm your nurse for the evening. I'm just checking in to see if there's anything that you need. I'm going to give you your call right here. I want you to let me know if there is anything that you need. I'm going to go make my rounds, and I will be checking back with you to see how you're doing. Hi, Mrs. Smith. My name's Amy. I'm your nurse for the evening.
Hi.
Here's some tissue. I can't imagine what you're going through right now. Hey, Mrs. Smith, I'm going to have to go and check on my other patients right now, but just know when I'm done, I will be checking back with you to see if there's anything that you need, okay? My name is Amy. I am your nurse for the evening. I'm just checking to see if there's anything that you need.
Yeah, a doctor. He said he was going to be here an hour ago, and everybody keeps telling me things, and nobody does anything.
I sense that you're frustrated. Let me step out and page the doctor and see when he will be able to come and visit with you.
Fine.
Hi, my name is Amy. I'm your nurse for the evening. I'm just checking in to see if there's anything that you need at the moment.
I'm good. I'm just wondering, I'm kind of wanting to get out of here, and I was wondering if there's anything I could get started on.
Actually, I can step out and get your discharge papers started. I will page the doctor to see when he's able to come and visit with you. We need to make sure that you're stable enough for discharge.
The clips we have just watched are meant to be springboards for your own creativity. They are examples of a few ways it might be appropriate to interact with perinatal loss or infant death patients and their families. Remember, your approach may be different after hours if, for example, you know that a social worker is not available, or if your unit is swamped and you don't have time to take 5 minutes and sit with your patient, or if there are complications and your patient who wants to leave as soon as possible is going to have to be admitted overnight. The most important thing is to try to connect empathetically with your patients in order to meet them where they are emotionally and spiritually. As I have stated, the ability of the care provider to connect empathetically to their patients and families experiencing perinatal loss or infant death is one of the primary ways to provide spiritual and emotional care. However, this connection can take a toll on the care provider. Finding that emotional place within yourself is difficult to turn off and on at the drop of a hat. Therefore, if we want to be able to keep providing quality care to our patients, we need to be aware of and understand our own emotional responses, as well as consciously and consistently practice healthy methods of coping and self-care. Care providers in an acute setting often experience something called cumulative grief. There is a saying that grieving multiple losses is not like adding one loss to another. It is like multiplying them. If we do not take the time to properly attend to the losses in our lives, whether at home or at work, then we will find ourselves in a very difficult situation. The most important thing to remember is that everyone responds to loss differently. Secondly, there is no proper timeline for recovering from a loss. A loss from 20 years ago can return to your consciousness just as easy as one from 2 months ago. We often veer towards avoidance when dealing with multiple losses. It is a short-term solution that allows you to get through the day, to keep working. However, it is not sustainable. Coupled with avoidance, we often use unhealthy coping mechanisms such as alcohol, smoking, drugs, binge eating, and other things to keep from acknowledging the pain inside. When we stop these numbing activities, the grief comes back tenfold because we have not been dealing with it. One common way to deal with cumulative grief is to bottle it up. When we bottle our emotions up inside us, we get into the habit of not feeling. Initially, we might be able to only bottle the bad things, or only the things from work. But emotions are connected. By purposely not feeling certain things, it makes it harder to feel anything. Bottling it up, similar to avoidance, is only a temporary measure. It can be useful in the short term. However, the longer you go without letting your emotions free, the harder it will be when that bottle finally explodes. And it will explode. Sometimes we fall into an opposite reaction, oversharing. If we are not dealing with our grief in a productive way, we begin to overshare. Every conversation leads to telling our story or saying how we feel, but it is not productive sharing at appropriate times. Rather, it is more like rubbernecking an accident. We keep our eyes on it, unable to set it aside, but we are not doing anything to help it. While family and friends will most likely be compassionate towards us if we are coping by oversharing, it is not appropriate with patients or colleagues. You may have experienced a perinatal loss or other death. It may seem like a good thing to tell your patient or family all about it and how you dealt with it. However, more often than not, your patient and family is going to be overwhelmed with their own grief, not ready to move into hope yet, and not able to deal with someone else's grief. This does not mean you cannot use your experiences to better understand how to care for your patient and their family. It just means that telling them explicitly about what happened to you and giving advice or platitudes is probably not going to be helpful. Instead, think back to what you went through, what you were feeling, and use your remembrance of those feelings to be respectful and compassionate to your patient and their family. We are now going to move on to discuss some healthy methods of coping and self-care. Sometimes something really difficult, such as a miscarriage, happens while you are in the middle of a shift. It can be hard to find a moment for self-care in the middle of a busy shift. However, there are a few simple things that take very little time that might be able to help you get through your shift without having to resort to unhealthy coping mechanisms. First, if you have a 15-minute break, take it and go somewhere that you can take a few minutes for yourself. CHI St. Alexius has several places geared towards just that. The chapel is open 24/7, and both the large chapel and a smaller vestibule have places to sit. There is also the solarium, or even just going outside to get some fresh air for a few minutes. However, I know it can be difficult to get away for an extended period of time, or that sometimes we need to use our breaks for food or going to the bathroom or making an important phone call. If you need a moment for yourself but don't have 15 minutes, then there are still some things that you can do. The chaplains are available for staff to take 5. The chaplains are available 24/7 and are always happy to come and talk with you for a few minutes, to let you debrief, to say a prayer, or to just sit with you. This can take as long or as little time as you have. Some other things you can do are to go to the bathroom to throw some water on your face. While you're there, look at yourself in the mirror and tell yourself something you need to hear, such as, "You are awesome, you can get through this," or "God gives me strength," or whatever you think you need to hear. Another way to take a moment to yourself is to carry a picture of your kids, your spouse, your pets, your best friend, or someone or something that makes you happy. When you need to, take the picture out, look at it, and remind yourself of one reason that person or animal loves you, or one reason you love them. It only takes about 15 seconds, but it can give you a lift to make it to the end of your shift. When we experience traumatic situations, we can be injured emotionally. Just as we would go to the doctor if we broke our legs in a car accident, if we experience emotional trauma after a difficult event, it is important to speak with a professional who is trained to help us heal. CHI St. Alexius provides an employee assistance program. The EAP is available for individual counseling if needed, as well as group debriefing for traumatic experiences. Additionally, most insurance companies have some form of short-term counseling available. If you need help to find professional assistance, you can ask one of our social workers, and they can guide you in the right direction. Often the place we find the most strength and healing is with our friends and families. However, it can be difficult to go to them for support when we are worried about violating HIPAA if we tell them the specifics about what happened in our day. It is not appropriate to share details about patients and families we have provided care for. That does not mean we cannot talk to our family and friends about how our day went or the emotional fallout of whatever medical traumas occurred. Instead of answering the question of "How was your day?" with "fine" or "tough" and leaving it at that, think about how what you experienced actually made you feel. You could answer with, "I dealt with a really difficult situation today. It was hard because I really wanted to help make it better, but there was nothing I could do. It made me feel so powerless." Just because we cannot share specifics doesn't mean that we cannot get the support that we need. Self-care can be one of the hardest methods of coping to do properly. It is often difficult to know what exactly self-care is. However, Eleanor Haley uses a really good acronym to help us think about self-care in her article, Self-Care for the Rest of Us, on whatsyourgrief.com. It's BAR, balance, awareness, and realism. First, balance can have several meanings. Perhaps it's finding a balance between caring for others and caring for ourselves, or a balance between a really satisfying but unhealthy method of coping, such as drinking or smoking, and methods of coping that help us to be more healthy and have a positive impact on our lives. Second, awareness is simply having the ability to take stock after a difficult event and admit, "Maybe I'm not doing so well with this." This can be one of the most difficult things to do. The further we are into avoidance or feeling down, the harder it is to be self-aware. Finally, realism is the idea that we need to be realistic about the self-care goals we set for ourselves. If we know we only have 20 minutes to spare each day, setting a self-care goal of going on a 10-mile hike is unrealistic, and failing to do it will only make us feel even lower. Self-care can be anything from taking a walk or sitting outside, to doing volunteer work, to reading a fun book, to taking time to unplug, to pretty much anything that gives you peace or gives you a more positive outlook. It doesn't have to be super complicated or take a long time. It just needs to be conscious and consistent. Thank you for joining me today to learn more about spiritual and emotional care during perinatal loss or infant death. If you have any questions or comments, please feel free to contact me by phone at 701-530-7672 or via email at hkbaggett@primecare.org. Additionally, I would greatly appreciate it if you would fill out the survey linked on your screen. It will help the Spiritual Services Department improve any future educational offerings. Additionally, all those who fill it out will be entered to win one of 3 $10 Starbucks gift cards. Thank you so much and have a blessed day.